Agatha Christine Onyango. I'm from the Department of Nutrition and Health, School of Public Health, Maseno University, and I'm a nutrition lecturer. I'm a senior lecturer in the department. Thank you for this opportunity. So today I'll be sharing nutrition in HIV, and I'll be co-presenting with my colleague. My colleague is a clinical nutritionist. Specifically, she specializes in pediatrics nutrition from Jaramogi Oginga Odinga Teaching and Referral Facility. So she will be seeing us through pediatric nutrition in HIV. So I will give the introduction, talk about the various researches in nutrition and HIV. Then finally, she'll come in with pediatric nutrition. We'll concentrate more on that. She'll tell us what is going on. When children are not thriving, what would you do, etc. And then we shall have the discussion question session.
Wonderful.
So
Well, warm welcome and thank you very much.
Thank you, Sherry. So I will share my screen. Okay. Okay, can you all see my screen? Okay, yes. Great. Okay. So this is my presentation outline. So I'll just basically see us through some of the general key factors on HIV. And then we shall be going through nutrition and infection. And then we shall look at some of the key nutrients that are very important in immunity, in the immune system. And then I'll take you through the nutrition assessment methods that we basically make use of when we are assessing. We can make use of those methods when we are conducting research. You can decide to use them all. You can decide to use 2 of them or even 3 of them, but at least you must combine at least 2 or more of the methods. Then I will go through 3 to 4 studies that will back up what I'll have presented earlier on. And then lastly, we shall have Ms. Rose coming in just to share with us pediatrics nutrition and HIV. Okay, So HIV continues to be a major global public health issue, and we have about 34.7 million people who live with HIV and AIDS so far. That is as at end of 2020, and an estimated 37.6 million. That's about over 2/3 of whom are in the WHO African region. So you can see that there is a higher number of HIV persons in the WHO African region. And then we have 690,000 people who have died of HIV-related causes in 2020, and about 1.5 million people who were newly infected by the end of 2020. Now we have the 1990. This is the UNAIDS ambitious target. And what we mean by 1990 is that the UNAIDS expects that at least, as at the end of 2020, we had at least 90% of all people living with HIV knowing their status. And then of this 90%, at least 90% of people diagnosed with the infection have received ARVs. And then of this 90%, of those who have received ARVs, they expect that they will have viral suppression. So this is an ambitious target, but this is what the UNAIDS expects, so that at least, though the COVID-19 affected the ambitious target by UNAIDS, but this is what they expected, so that at least 90% of those who are on ARVs are having viral suppression and they're able to live longer. Now, as at end of 2020, 84% of those living with HIV knew their status. And then among these, 87% were able to access the ARVs. And then among the ones who were able to access the ARVs, 90% had viral suppression. So of all people living with HIV, 84% knew their status, 73% were accessing treatment, and 66% were virally suppressed by the end of 2020. So let's look at nutrition and infection. It is known that there is a relationship between nutrition and infection, but what is this relationship? So when we have an infection, there's normally poor nutrition increases vulnerability to infection. So you'll find that there'll be more infections because one becomes more vulnerable to infections. And then these infections will cause and aggravate poor nutrition. So there's that synergistic relationship between nutrition and infection. And at the same time, you'll find that when there's poor nutrition, there's a weakened immune system. And there will be increases of incidences, severity, and duration of infection. So one might take a longer time to heal. It might even become worse when one is undernourished. Now, the symptoms of infection would lead to weight loss, growth faltering, and further weakening of the immunity. And this is very common in HIV infection. There is normally weight loss, and growth faltering is common in children under 5, and weakening of the immune system. Effect of on the immune system. Once we have poor nutrition or we have undernutrition, HIV progressively destroys the immune system. And this often leads to opportunistic infections and debilitation. So you'll find once the immune system is weakened, then the person is prone to other infections and mainly the opportunistic infections, that is the OIs. So when there's pre-existing undernutrition, it makes it very difficult for someone living with HIV/AIDS to stay healthy and even productive. So both HIV and undernutrition will limit the ability to fight infection. And we are going to see that when we look at micronutrients and immunity. So we usually have the vicious cycle of malnutrition, where we have the relationship between nutrition and HIV. So when we have that vicious cycle, what usually happens, we'll have weight loss, we may have muscle wasting.
I'm Rose Awino Ochindo from Sierra County. Your name is unique because
is somebody talking?
Has made me.
So we have loss of muscle tissue and body tissue because the body now starts making use of the proteins, making use of the fats. We have vitamin and mineral deficiencies. And at the same time, we also have increased nutritional needs. The immune function is also affected, and one becomes susceptible to infections, and there's also weakness and reduced productivity. That is the quality of life. So this shows us the vicious cycle of malnutrition. Just trying to look at the relationship between nutrition and HIV. So when you have poor nutrition, it impairs the immune system. And this leads to increased vulnerability to infections. And therefore, the body now requires more nutritional needs. So the nutritional needs increase. So it's a cycle, a vicious cycle that goes round. You have poor nutrition, impaired immune system, then more infections, and then your nutritional needs also increases. Then when you have nutrition interventions, when we have had nutrition interventions, we will have a stronger immune system, we'll have reduced vulnerability to infections, and also nutritional needs are adequately made through the recommended dietary allowances. And therefore, this shows that once somebody is infected with HIV/AIDS and they having good nutrition, they have a stronger immune system, and their length of life can be prolonged. So nutrition also, we normally have nutrition effects on HIV. When one is undernourished, the immune system is affected, it becomes weaker. There is also increased susceptibility to OIs. We also have slow wound healing and possible faster disease progression. So during times when one is undernourished, they move faster from one phase of HIV to another. Then we also have poorer response to treatment because there are key functions for various nutrients. And therefore, if there is inadequate intake of nutrients, then even the medication that is taken, there will be poor response to it. Then also sense of despair and depression comes in when we have poor nutrition or undernourishment. Now, HIV also has effects on nutrition. We have three main effects of HIV on nutrition. We have reduced food intake, we have increased energy needs, we have an altered nutrient metabolism and absorption. So when we look at reduced food intake, one will have symptoms of OIs, which includes mouth sores, taste changes, nausea, appetite. And when somebody has, for example, mouth sores, they are not able to eat well, and therefore their food intake is reduced. When one has nausea, the same thing, even appetite loss. We also have reduced effects of medication. Certain medications, certain ARVs that are taken may have side effects, and that would result into reduction in food intake from a person. We may also have reduced quantity or quality of food. When one has, for example, like the OIs, one will not be able to take enough as is recommended. Now, we also have increased energy needs. Now, this can be as a result of viral replication and OIs. Now, during the asymptomatic phase, normally the energy needs go up by more than 10% of compared to a healthy person. And then during the symptomatic phase, normally the energy needs go up by 20 to 30%. And in children, the energy needs are even higher, about 50 to 100% compared to the healthier people. Then we also normally have, when we look at the recommendations for protein, fat, and micronutrients, normally it is the same as a healthy person. So when there is HIV infection, you will find that the protein, the fat, and the micronutrients are usually affected, yet they are supposed to take just the normal recommended daily allowance as a normal person. And for the energy intake, usually proteins, we normally get 12 to 15% of the protein, of the energy that we take from the protein foods. And if one is HIV affected, it means that the body ends up making use of the protein. And that is why we normally see wasting in most of the HIV persons. We are also saying that the micronutrient allowance remains the same. And oftenly you will find that in HIV infection, one is more prone to deficiencies, yet we are supposed to take, they are supposed to take the recommended daily allowance just like the healthier persons. Now there's also poor absorption. And this can be caused by HIV infection and the OI. So we usually have diarrhea. One can have diarrhea. This is very common in HIV infection. And when there's diarrhea, there's usually loss of electrolytes, and that can cause imbalance. And this can occur at any stage, at any of the 4 phases of HIV infection. And we also have loss of excess nutrients. When there's vomiting, there's diarrheaing, then of course one loses nutrients. Now the AIDS-associated wasting syndrome, we have increased morbidity and mortality. Now, when we have that progression, there is that likelihood that one will develop the comorbidities that may lead to mortality. And it is also associated with reduced energy intake. Oftenly, you'll find when one progresses from HIV to AIDS, there is reduced energy intake, there is wasting, infections, the GI, we have GI disorders, including diarrhea and malabsorption. And when there's malabsorption, it means that also nutrient intake is affected. There is also metabolic changes that takes place. Now, we also have changes in body composition. Now, oftenly the body will respond differently after illness. So we usually have amino acids used for energy. That is the proteins. Amino acids are the building blocks for proteins. So as I said earlier on, when the body ends up making use of the proteins, then one gets wasted because proteins are bodybuilding, and therefore their main function is not for energy, but they can provide some percentage, the 12 to 15% of energy. Now, fats also continue to accrue. And oftenly one may have the fat syndrome, malabsorption syndrome, that is the lipodystrophy. So we have accumulation of fats. And then nutrient intake may be adequate, but then inadequate in storage and use. Remember, when we have vomiting, we have diarrhea, you may be taking in enough nutrients, but then it's not being stored and the body is not using it because of malabsorption. And then we also have increased resting and energy expenditure in HIV infection. Now, this figure just summarizes the HIV progression and the nutritional impacts, right from the initial infection up to when an individual has AIDS. And we can see at the initial stages of HIV infection, in all phases, we have increased nutrient needs. Then as we move on from one phase to another, we have reduced intake, weight loss, wasting, and metabolic alterations. So by the time an individual progresses up to the last phase where they now have AIDS, they will be having issues even with metabolic changes. So during their symptomatic phase, the energy and nutrient needs normally increase because of virus replication. And that is why during this phase, usually the energy needs increase in adults between 20 to 30%, and in children between 50 to 100%. The same thing occurs during the symptomatic phase, even more, because remember, during this time, the virus replication is even higher, and it becomes worse, especially if one is undernourished, and the effects of HIV-related symptoms are now present. So I want to take us through this other session, which is just touching basically on micronutrients and the immune system. And oftenly, when one is diagnosed with HIV, they're usually put on multivitamins, which includes the minerals and the vitamins. And these are the micronutrients, and they're usually consumed in small amounts, but they play a significant role in the body. So micronutrients have a relationship to antibody formation and the development of the immune system. They are very, very important. They are key in the immune system. Now we are talking about micronutrients. That doesn't mean that the macronutrients are not important. The macronutrients are equally very important, and they provide the energy that is needed by the body. Now, a point to note is that the nutrients work as a team. they do not work in isolation. Each nutrient has its main function, but then you'll find that if one is deficient in one nutrient, it will affect another nutrient. So one of the key nutrients in HIV infection is vitamin A. Now, vitamin A is very important because it maintains the integrity of the epithelium in the respiratory and tract infections. So most of the times when we have infections, it is recommended that we increase our vitamin A intake. Now, the deficiency would results in diarrhea and also developing respiratory diseases and overall mortality. So the supplementation of vitamin A will sustain the gut. It will also reduce incidences of RTIs and also mortality that may arise from diarrhea. And it also enhances the immune system because vitamin A is also an antioxidant. It fights free radicals in the body. Now, the other important micronutrient, which is a vitamin, is vitamin E. And vitamin E is also referred to as the antioxidant vitamin that fights free radicals. And usually its supplementations help improve the immune system. And this is quite important amongst the elderly because it delays the hypersensitivity skin response and antibody production after vaccine. Now, it also increases both cell dividing and interleukin producing capacities of naive T cells, but not of the memory T cells. These are cells that are very important for fighting infections. We also have vitamin D. Vitamin D is very important. It is cheap, but very effective in the immune system. And it boosts against tuberculosis, which is one of the common opportunistic infections in HIV infection. Now, research reports that a single dose, that is about 2.5 milligrams dose, is sufficient to enhance the immune system's ability to withstand infection. Now, these findings came from a study that identified an extraordinary high incidence of vitamin D among tuberculosis patients. That is, they were female in a Muslim community, and this study was done in London. So a single dose of 2.5 is sufficient enough to boost the immune system. We also have zinc. Zinc is a trace element. That means it is a micro mineral taken in dosage that is less than 5 milligrams. And it is essential for all species. It is usually required for more than 300 enzymes. It is very important for carbohydrate and energy metabolism, protein synthesis, and degradation. It is also important for nucleic acid production, heme biosynthesis, and carbon dioxide transport. So zinc plays quite a number of roles, and it's one of the key minerals that are normally given to mineral supplementation that is given to HIV-infected persons. It also plays a key role in the structure of cell membranes and in the function of immune cells. Very important in the function of immune cells. Now, if there is a deficiency of zinc, it reduces non-specific immunity, including the neutrophil and natural killer cell function and complement activity. It also reduces the numbers of the T and B lymphocytes, and we know how important these are in fighting infections or preventing infections, and also reducing the antibody production. Now, inadequate supply of zinc will prevent the normal release of vitamin A from the liver. As I said earlier on, the nutrients work as a team. So when we have insufficient amounts of zinc, then that will hamper the release of vitamin A from the liver. Now, low blood zinc concentrations has been found in patients with the TB, diarrheal disease, and pneumonia. And we have seen that these are conditions that are common, like pneumonia is also very common amongst HIV patients. Diarrhea is common, TB is also common. Now, the deficiency is also associated with conditions of relative immune compromise, including kidney disease and HIV infection. So in essence, we are saying that it is associated with immunocompromised conditions. Now, its supplementation will reduce the duration and intensity of diarrhea. Zinc supplementation is very important when one has diarrheal episodes. It is commonly given even among healthy patients to reduce the episodes of diarrhea. Now, low blood zinc concentrations have been found in patients with TB. This one I mentioned earlier on. Iron is also very, very important. It is a trace element, but quite important. And we find that iron deficiency is very common, and it affects about 20 to 50% of the world's population. And this is very common among infants, children, and women of childbearing age. It is also associated with impairments in cell-mediated immunity, reductions in neutrophil action, with decreased bacterial and myeloperoxidase activity. It also lowers the body's defenses against disease and diminishes body and brain function. Lastly, we look at selenium. Selenium is also a trace element. It is a mineral, a micro mineral, and it is just like zinc, it is also essential for proper body functioning, and it is an antioxidant that fights oxidative stress and helps defend the body from chronic conditions such as heart disease and cancer. And it plays quite a key role, especially in HIV-infected persons who also have cancer. It plays a critical role in metabolism and very critical in the thyroid function, and it protects the thyroid from oxidative stress. Now, research shows that selenium can suppress the progression of HIV viral burden and also provides indirect improvement of CD4 cell count. So I'll just briefly see us through the assessment methods that we can be able to make use of. For example, if you wanted to conduct a research, what are some of the methods that you can make use of in trying to probably assess so that you can have an intervention? If you want to conduct probably clinical trials, you want to get to know what the HIV persons are eating, you want to look at clinical signs, etc. So we usually take the measurements to identify and track body composition changes over time. And this is very, very important because progress is seen when you track the body changes, and we shall see which are some of these methods that we make use of in tracking the body changes in HIV infection. So we look at weight, very important. We look at changes in body cell mass and fat-free mass. We look at serum nutrient levels, cholesterol. Now, there's also we use these measurements to design appropriate interventions. Once we know that one is undernourished, then we have appropriate intervention. And they can also be used to address client concerns about their health. These measurements can also be used to meet increasing emphasis on physical nutrition assessment as part of clinical trials. So what we measure, we normally have anthropometry, we have laboratory tests, we have clinical assessment, and we have dietary history and lifestyle. And I will explain in details shortly. So with anthropometry, we normally assess and monitor weight. Remember, weight is very, very important in HIV infection because oftenly it is used to determine the kind of intervention that an individual will be given. So we have weight and height is used to calculate the body mass index that is commonly known as the BMI. And a BMI of less than 18.5 kilograms per meter squared, one is considered undernourished in HIV infection. It is also used to assess percentage of weight and or body mass index changes over time. So when a patient comes into the clinic, usually they take the height and the weight and they classify the results into normal, undernourished, overweight, or obese. Anthropometry can also be used to assess and monitor body composition. Here we want to look at lean body mass, the body cell mass. We also have the skin fold thickness that will determine the amount of fat around the triceps, the biceps, and the mid-thigh. We also have circumferences, and the most common one is usually the mid-upper arm circumference, commonly known as the MWAC. But we can also have the waist circumference to determine the amount of fat around the waist. We also have the hips, the mid-thigh, the breast size, and the neck circumference, commonly known as the buffalo hump. Then we have the laboratory measurements. These are now the biochemical markers, and the biochemical markers are normally very important in assessing nutrient levels. Now here we normally look at the serum micronutrients. We have hemoglobin and ferritin to detect iron deficiency. And then they can also be used, the biomarkers can also be used to assess and monitor body composition. And this includes fasting blood glucose, lipid profile, specifically looking at cholesterol levels and the triglycerides. And then we also have serum insulin monitored. Then we have the clinical assessments. So clinical assessments, basically here we look at the symptoms and the illnesses associated with HIV and AIDS. So we want to find out whether there is presence of diarrhea and vomiting. Is there fever, mouth and throat sores, oral thrush, muscle wasting, fatigue or lethargy, skin rashes. So basically it's just to look at the signs and symptoms. Let's see. Then we have edema. We have pallor, especially if we want to check for iron deficiency. Then we have, the last one is the dietary history. Now the dietary history just basically involves trying to find out what one has consumed. And this can be done in the last 24 hours using what we call a 24-hour dietary recall. You can also have, you can also look at the frequency of the meals. You can use a frequency checklist to assess. And here you can look at the types and amounts of foods eaten. You can look at the supplements, you can look at the medication. And because we are talking about diet history, you can also look at factors that would affect food intake, like appetite, medication, lifestyle. You can also look at the indirect indicators like economic factors, because they really determine what one takes. So lastly, let's just look at a few studies. that confirm what I've just previously talked about. So we have a study that was done in Nepal, and this study was looking at nutritional status and its association with quality of life among HIV patients. And this particular study made use of anthropometry. They were making use of the weight and the height. And they found out that Rashgir, Thapa et al. Found out that one out of every 5 individuals were undernourished, which means they had a BMI of less than 18.5. In the same study, illiteracy, residence in home cares, CD4 cell count that is less than 350 cells per milliliters, per cubic milliliters, OIs, and illness at WHO clinical staging 2 and 4 were found to be predictors, significant predictors of undernutrition. So it meant that if one had no information or was residing at home, or the CD4 cell count was less than 350, presence of OIs, especially in stage 3 and 4, these were predictors of undernutrition. And therefore, this study recommended that nutrition interventions should form an integral part of HIV care. And the study also said that understanding the presence of OIs, declining CD4 cell count, or even advancing in WHO clinical staging, there are risk factors, and this can be helpful in preventing undernutrition from developing. So this study basically just made use of anthropometry. Now, there was another study also done in Ghana. This one particularly just looked at nutritional status and the associated factors among people living with HIV, study by Beauty et al. And basically this study was just trying to look at knowledge and in association between knowledge and malnutrition and amongst HIV persons. And the results revealed that those with good nutrition related knowledge, and these were over 50%, were more likely, those were less likely to be malnourished compared to those who had poor knowledge as far as nutrition was concerned. So here again, we see there's that link between just having that idea of what to eat, when to eat, and how to eat, and improvement of one's nutritional status. There's also this study that was done in the US amongst HIV-infected adults by Tupal et al. They were looking at both male and female, and this study made use of the biomarkers and also made use of dietary assessment. And the results were that adults, the HIV-infected adults, had higher serum protein. And this, the higher serum protein in HIV-infected persons could be associated with a group of immunoglobulins and possibly progression, compromised immune system, which means one could have been progressing to probably from one phase to another. Then also there was a lower serum albumin and lower serum folate than those who are non-HIV infected. So this study had both HIV infected and non-HIV infected, and they were comparing the two groups. So in the same study, there was no significant differences observed for triglycerides, glucose, or even the red blood cell folate within the sexes, that's the male and the female, by HIV status, or within HIV-infected individuals by sex. Now, the HIV-positive men had lower concentrations of total cholesterol than the HIV-negative men. So they had 4.7 compared with 5.0 millimoles per liter. And this is quite common, especially in instances where we have wasting and probably the body may be using fats for energy production. Then the HIV positive women had substantially lower serum, that is 25 hydroxyvitamin D concentration than the HIV negative women, that is 47.3 compared to 64.9 nanograms per liter. Then both the males and the females, that's the HIV infected adults, had higher serum protein compared to the non-infected. There was also no difference in energy intakes in both sexes as far as HIV status was concerned. And then the HIV positive women had significantly different intakes of fiber compared. So we had a mean of 9.2 compared to a mean of 14.7. And then the protein, about 83.5 compared to 71.3 than the HIV negative women. So we find that there was a significant difference in fiber and protein intake between the HIV positive and the HIV negative women. Then among the men, there was no significant differences in dietary intakes by HIV status, except for vitamin B6, that is pyridoxine, which was lower in HIV positive men compared to the HIV negative men. Then compared with HIV negative women, the HIV positive had lower intakes of vitamin E, vitamin K, magnesium, and potassium. So these are the micronutrients that are key in immune function. Now, in conclusion, HIV affects nutrition through reducing food consumption, impairing nutrient absorption, increasing energy needs, causing HIV-associated wasting, changing metabolism, and also changing body infection. And when we have poor nutrition, this would affect HIV by reducing the immune system, slowing the healing process, and possibly hastening disease progression. So I can conclude by saying that a global recognition, there is global recognition that good nutrition is the key in sustainable development. Why do I say so? It is because it promotes good health. And this is one of the SDGs that we are to achieve, one of the 2015 SDGs, the second SDGs. And when one is nutritionally sound, one is healthy, then one can be productive. So I will stop there. And probably if there is any question, I can respond to any question, or we can, Sherry, what do you say?
Oh, nothing. I just, I was just gonna, first of all, thank you for an excellent overview and for covering so much material. And while we're waiting for other people to ask questions, I have one. We have sometimes struggled in our HIV studies to figure out the best way. We haven't done 24-hour recalls, which I know is the gold standard just because of time and logistics and a few other things. So I guess my two questions are, we have struggled a little bit with food frequency questionnaires and finding the right one. And we've had some very comprehensive ones. And it just, there's always limitations with, how much information you're getting from those. So I am just curious if, you can talk a little bit about what are what are your sort of go-to food frequency questionnaires in the region that you've used, and talk about maybe some successes in administering 24-hour recalls in research in this setting that we could, maybe all consider for our future studies.
Okay, thank you, Sherry, for the question. Yes, I have made use of 24-hour recall. I do agree with you that it is tedious, but it is one of the gold standards. Actually, it is the tool that we normally make use of when we want to look at meal frequency, we want to look at nutrient intake, and then compare it with the recommended daily allowances. The challenge with it is that you have to physically actually even take the measurements for you to have accuracy of what one is actually consuming, so that you're able to determine the amount of nutrients from the different foods that you're looking at from the 24-hour recall. Now, with the food frequency, now we have the food groups from FAO. Normally, we make use of either the food groups from Fanta or the ones from FAO. And oftenly with the food frequency, what you do is that you try as much as possible to customize it within the region that you're going to, because you're going to be asking the frequency in which they consume certain foods, and those foods must be within the area that they're coming from. So I find it an easier tool to make use of compared to the 24-hour recall, because all you need to do is just to do your market survey and find out which foods are in that particular area. Then now you have the food groupings as per either the FAO tool or the Fanta tool, and then now you can use that and administer it in a household, an individual, whether in the facility or you're doing it within the community.
Thank you. So we would love to hear questions from students. Or Dr. Agatha, do you have any questions you want to ask the students to pose and reflect upon?
Probably before I ask any question, Sherry, maybe I would want to ask Rose just to see us briefly, maybe for just about 5 minutes, 10 minutes on pediatric nutrition in HIV, just to share her experience. Yeah. So let me just share a slide so that she can make that presentation, maybe in just some 5-10 minutes before we look at the discussion questions.
Great.
Okay, Rose, you can.
Hello, everyone. Yes, I'm going to take us through pediatric nutrition and HIV. Can you hear me?
Yes, we can.
Can you hear? You
Yes,
can,
yes, yes, we can.
Okay. I'm going to narrow my presentation to infant and young child nutrition in the context of HIV and AIDS. I'll start by saying our aim as we look into the infant and young child nutrition. So our main aim is to improve child's nutritional status. And it all begins with the prevention of transmission of HIV to children, as we are all aware that virus can always be transmitted to the child through breast milk. Another reason why we emphasize so much on infant young child nutrition is to ensure that these children get optimal nutrition, because optimal nutrition determines child's health, cognitive function, and physical development. Optimal nutrition for the first 1,000 days of life improves quality of life forever. There are policies used for feeding children in the context of HIV, AIDS, as discussed in the next slide. Next slide. Are you getting me?
Yes.
Okay. So
Yes,
here
we're getting.
we have. Is it okay? Okay. Now we have the policy guidelines for feeding children. When we have mothers who are known to be infected, the policy guidelines says that the babies should be breastfed exclusively for the first 6 months. And then we introduce the complementary feeding is supposed to be introduced timely and appropriately as breastfeeding continues up to 2 years. And again, both mothers at that particular time, both shall receive prophylaxis and antiretroviral treatment in the line with the national recommendations. When a mother chooses not to breastfeed, when the mother chooses not to breastfeed, she can do exclusive replacement feeding based on acceptability, feasibility, affordability, sustainability, and safe. In bracket, we always abbreviate it as AFAS. At the same time, when the mother who is known to be infected with HIV and the child is already infected, the babies are supposed to be exclusively breastfed for 6 months. At the same time, we are supposed to do timely and appropriate complementary feeding and continued breastfeeding up to 2 years. Yes, next slide. Next slide. Yes, however, you find that the policy guidelines have been implemented, but they have been implemented with gaps. Many a times we have non-compliance with the policy guidelines, that is poor breastfeeding practices. We find that most mothers do breastfeeding. At times also exclusive replacement feeding can be chosen on, however, it is not a fast. Untimely and inappropriate complementary feeding is also done that results in, number one, failure to thrive, that many a times we call FTT, and this one is in children who are below 6 months. So failure to thrive is a form of acute malnutrition that occurs in baby below 6 months of age. And it occurs due to inadequate dietary intake, which can be related to mixed feeding, poor breastfeeding techniques, exclusive replacement feeding that is not a fast, inability to access mother's breast milk in case of death of a mother, or the mother can be very sick, too sick to breastfeed her baby, and also opportunistic infections and mother psychological issues that can always interfere with mother's milk letdown. So what are the indicators of failure to thrive? Babies who are having failure to thrive, babies under 6 months, when we always score them, you'll find that the weight for age score is always below -2 standard deviations. These infants, at times, they are too weak to suckle. Some babies are not getting weight at all at home. For example, a child was born with a good weight, 3.5. You find that still even at 5 months, the baby is still below the birth weight. Another indicator would be the presence of bilateral pitching edema and also reduced weight. So these babies are always eligible for admission. Next. Yes, are you getting me? Yes. Hello,
Yes, we are
Yes,
getting
we
you.
are getting you.
Yes,
We are
yes.
getting you.
Yeah, we're getting.
Yes, continue. The
That
next
is
slide.
great, huh? So we also have our goals for the management of this baby. So what is really our main goal? We always manage them. Our main aim for management is to stimulate breastfeeding and supplement breast milk until it is adequate for the growth and the development of the baby. Another aim is supporting breastfeeding when the baby has not been feeding well with supplemental suckling technique till the baby is able to breastfeed well. Another aim is to ensure optimal nutrition when the baby cannot access breast milk. Next slide, Dr. Agatha. In the event that, now I'm talking about the management of the failure to thrive. In the event that the breast milk is inadequate to meet the daily needs of a child, we always give the dilute F100. Dilute F100, the therapeutic feed that is provided at 130 ml per kg body weight per day, and it is divided in 8 meals. And in case of edema, F75 is provided 100 ml per kg body weight per day until the edema resolves. Thereafter, we graduate dilute F100. Meanwhile, the baby continues to breastfeed. So dilute F100 is prepared by preparation of full strength F100, and we add 30% of the total water that was used in the preparation. So F100 is used to rebuild waste tissues. That is 100 ml of F100, which is too fast. 100 ml of F100 is equal to 100 kilocalories. So F100 has 11% of total energy as proteins. It also has 51% as lipids, and then it has omega-6 fatty acid of 7%, and omega-3 fatty acid of 0.6%, and carbohydrates is 38% of the total energy, meaning that the majority of energy is derived from lipids. Next. F75 is used for cautious feeding. The nutrient density is lower than of F100. That is, in 100 ml, we have 75 kilocalories. So from the total energy, proteins are at 5% and lipids are 30%. Omega-6 fatty acid is at 7%. Omega-3 fatty acid is at 0.7%, and carbohydrates is 65% of the total energy, meaning that majority of energy is derived from carbohydrates. We also have the micronutrients available in both of the therapeutic feeds, that is F75 and F100. And here is a list of the micronutrients that are available in them. We have the calcium, we have the phosphorus. We have the phosphorus. Okay, we have the calcium, phosphorus, we have the magnesium, we have the zinc, we have the copper, we have the iron, we have the iodine, we have the sodium, we have the selenium. The therapeutic feed, that is F100 and F75, they also have water-soluble vitamins. Those ones are the vitamin Bs and the vitamin Cs. They also have the fat-soluble vitamins, that are the vitamin A, B, and K. The nutrient composition of F75 and F100 are adequate to meet the recommended daily allowance. In the event when the breast milk cannot be accessed, the baby is introduced to breast milk substitute, that is infant formula 1. We have different formulas. So the baby will be introduced to the infant formula depending on the age of the baby, because the infant formula are mimic to breast milk. So when we are introducing these babies on the infant formula or the breast milk substitute, we make emphasis on the reconstitution. We talk of the frequency, how many times should the baby be fed per day. We talk also on the amount, that is the volume. And we also talk about the hygiene, so that our babies do not get even some infections upon feeding. And we make sure that the energy requirements are met at the end of the day. So below, another slide, the next. Here now we are having the therapeutic feeds. We have the F100. Next slide. Next slide. Yes, we have the therapeutic speeds here. We have F100. Back, the previous slide. Previous slide. Yes, we have now the therapeutic speeds here. We have F100, we have F75. I've managed also to give you the things so that you can read about the content. We are also having a mother who is now breastfeeding her baby using the method that is called the supplemental suckling technique. You can see the mother suckling her baby. You can see a tube that is dropped in some cup that is having some milk. We are doing this to stimulate milk production so that at the end of the day, the baby will be able to thrive well on breast milk. Next slide. The next. Yes. In a scenario when breastfeeding was stopped untimely, we always reinitiate breastfeeding using supplemental suckling technique, using dilute F100, still using the constants that were mentioned above until breast milk production is optimal and the baby can add weight without our support. Nutrition education and counseling is always done on infant nutrition, and maternal nutrition support is always offered. And what is the discharge criteria? When these infants reach a weight for height score of above -2 SD, we will discharge them home. More so if there's absence of medical problem. And when it is very clear that the infant is gaining weight on the breast milk alone after supplementary suckling has been stopped. Next slide. Next. So here, the next slide is talking about severe acute malnutrition in children above 6 months. So good nutrition status and early detection of HIV can slow the progression of HIV. People living with HIV have increased energy requirements just the way we were taught by the first presenter. So patients with severe acute malnutrition, daily requirements are increased by between 50 to 100%. Thus, some HIV positive patients require therapeutic care, though may take longer to recover. So what is the admission criteria for these children above 6 months with severe acute malnutrition? These babies, they always score their weights against their height score are always below -3 standard deviation, and they are also reporting medical complications. You do a mid-arm, if you do mid-upper arm circumference, they come up with a mark below 11.5 centimeters. And at times, some of them even present with bilateral pitting edema. Next slide. So the management of severe acute malnutrition in HIV and AIDS above 6 months is always being done in 10 steps. So the first step is to treat and prevent hypoglycemia. The second is to treat and prevent hypothermia. The third one is to treat and prevent dehydration. Number 4 is to correct electrolyte imbalance. Number 5 is to treat and prevent infection. Number 6, we have to correct micronutrient deficiencies. Number 7, start cautious feeding. Number 8 is achieve catch-up growth, provide sensory stimulation, and then we prepare for follow-up after recovery. Next slide. Next slide. Yes. So upon the management of dehydration, some of these children, they present with dehydration. So if you happen to get a child who is not in shock at admission, we always give Resomol. And the Resomol is being given via the tube. And we give, this is a child that is having severe dehydration. So what we do, we give Resomol. Resomol is rehydration solution for malnutrition. We do 10 milligrams per kg body weight per hour for the first 2 hours. And then after 2 hours, then we give Resomol at 7.5 ml per kg over 1 hour. Then we introduce the first feed with F75, and we will continue alternating Resomol and F75 at 7.5 ml per kg body weight per hour for the next 10 hours. After 12 hours, when dehydration is resolved, we'll start feeding the baby as per the Imam guideline. And there, I've given us the pictures of Resomol so that we know what Resomol is. Resomol is hydration solution for malnutrition. Next slide. Yes, we've talked about the 10 steps of management of severe acute malnutrition. And then step 1 talks about prevent, is about you prevent and treat hypoglycemia. So if a child happens to be admitted and then we learn that the child is having the blood sugars of less than 3 millimole per liter, we'll always give glucose sucrose water that can be given either orally, if the child is strong enough. If the child cannot take orally, we always pass an nasogastric tube that will be used to administer the glucoline water, water that is having some sugars, and that one is done within 30 minutes of admission. But when the child is unconscious, we give it intravenous. We give glucose intravenously. Thereafter, feeding will be done as per the Imam. Next slide. Next. Now we are talking about the phases of management of children over 6 months in the HIV context. Any other child having severe acute malnutrition is always being managed in 3 phases. However, these children who are having HIV, the management is being done in only 2 phases, being that their energy requirements are really elevated. So the first phase is the phase of stabilization. And then the second phase is the phase of rehabilitation. So in the first phase, at the phase of stabilization, we do what is called cautious feeding. And cautious feeding is done using starter feeds. That is F75. And we do it at 100 ml per kg body weight per day if a child is presenting with edema. However, if the child is not presenting with edema, we give at 130 ml per kg body weight per day. And the feeds are always divided in 8 meals as tolerated. With loose stool, we still continue giving Resomol at 7.5 ml per kg with every loose stool. Most patients with reduced appetite are fed entirely via NGT. With good appetite, dose edema, medical complication resolving, patients are graduated to rehabilitation phase for nutrient-dense diets. Next slide. Next. Yes, they are now being graduated to rehabilitation phase. So in rehabilitation phase, the formula 75 F75 is stopped and patient is weaned off NGT. Now you see the medical complications are resolving, the appetite is there. So we now introduce a more nutrient feed that is F100. We also give the ready to use therapeutic feed that is as good as F100 and other modified diet that can also be in form of a fortified blended porridge. So supplemental formulations are also given as they contain the RDAs for the selected vitamins and minerals and may be used concurrently with the RUTF. RUTF is the ready to use therapeutic feed in treatment of some. Typically, energy values are between 410 to 550 kilocalories per 100 grams. They can be added under the modified diet. Patients here in the rehabilitation phase, patients are feeding well orally. Therefore, the feed volumes are increased by 20 per day to a maximum of 200 meals per kg body weight per day. With this good intake, the feeding frequency is always reduced. So you find when you admitted them, they could even feed after every 3 hours. So this now a scenario where the feeding can be done even 5 times or 6 times in a day. In the rehabilitation phase, we expect a weight gain, and the weight gain expected is can be 10 grams per kg per day. Next slide. In the rehabilitation phase, we also do sensory stimulation. You find that many a times when they are having severe acute malnutrition, they are withdrawn. So sensory stimulation is also being done to bring them back to their environment. So once the target weight is achieved, that is at -2 SD, all medical complications resolved. On discharge, the patient is now enrolled on supplementary feeding program. That is what we put in bracket as SFP, and the patient is followed up for the next 3 months. Next slide. So here is a packet of RUTF, the ready-to-use therapeutic feed. A sachet is 92 grams, and in 92 grams, we have 500 kilocalories. Next. So RUTF yeah, from the total calories that we get, the total calories that is 500 kilocalories, we find that 10 to 12% is derived from proteins, and then 45 45 to 60 is from the fats, and then therefore that a lot of energy is derived from the fats. It also has micronutrients the way the other therapeutics, the F75 and F100 are. We have the vitamins that we have in the RUTF include vitamin A, vitamin B, vitamin C, vitamin B, vitamin E, and K. A sachet is 92 grams, and the 92 grams provides 500 kilocalories. The prescription, how do we give it? How will we know that we need to give a baby this number of sachets? We always have a formula, and the prescription for distribution or giving is, we always take the weight of the baby, we multiply by a constant that is 37, and then we divide by 92, that is the weight of 1 sachet. So as we do all this, we also do nutritional counseling on the age-appropriate nutrition. Next slide. Yes, moderate acute malnutrition in HIV and AIDS. So the criteria for admission, here the child would score -2 SD to -3 SD with medical complications. Those without medical complications are enrolled on a patient supplementary program. So from this slide, we get it that we only admit children who are presenting with moderate acute malnutrition with medical complications. These babies, their MUAC, the mid-arm upper circumference is between 11.5 to 12.4 centimeters. These babies, if you have a look at their growth chart, it is always declining. So how do we manage moderate acute malnutrition complications? Alongside management of medical complications, they are enrolled on supplemental formulations to correct their nutritional status. Next slide. Next slide.
We're already on the next slide, Rose.
Thank you very much. So the supplements, the formulations are designed to provide about 50% of the energy requirements. So they are composed of 70% of whole grains and lipids, along with approximately 1 RDA of key micronutrients, to correct deficiency and to prevent development of deficiencies in moderately and mildly malnourished children. Patients whose diet is inadequate with respect of the RDS and having borderline nutrition status, those who are at risk of malnutrition are also supplemented with 1 RDA multi-macronutrient formulations until their dietary intake is considered adequate and stable. The supplementary protocol is designed with the intention of drawing the remaining energy requirement from consumption of home foods to raise caloric intake by 2 to 2.5 times. They should facilitate a transition to home food upon recovery from malnutrition. Yes, next. Next. Yes, rehabilitation of moderately undernourished children have a fixed dose of 435 kilocalories per day or 10 grams of fortified blended flour for babies over 6 months old. And the discharge criteria, the children maintain their weight or height score above -2 SD or MUAC, or their MUAC must be of above 12.5 centimeters for a period of 2 consecutive weight measurements. Another thing that the medical complications must resolve is when we consider discharging them. And we gave a picture of the fortified blended flour, but the picture that we gave is for adults. We also have for children. So these are just, these are the flour for preparing porridge. They are made of cereals. However, they are fortified with vitamins and minerals. Thank you very much.
Okay, is Sherry there? Sherry, are you still with us?
She had to sign off, but Anka is
Hello?
still here.
Yes, I think Sherry may have left for another meeting, and
Okay.
I'm happy to guide the discussion. Rachel,
Please go ahead.
I don't know whether you can hear me.
Yes.
Okay, thank you so much. I'm really appreciative of that very rich and detailed presentation. Thank you so much, Rose, for that presentation. I think I've learned so much. Uh, it was very engaging, and I believe everyone on the in this uh, webinar has learned so much, and I could see messages streaming in, from the participants. Thank you so much, Agatha, Dr. Agatha. And probably I would like us to focus the few minutes that are remaining. Maybe we can ask, we can have some questions, some discussions based on the presentation. And maybe I could ask, I could start with a question. I was just thinking as Rose was presenting, I'm not so sure whether this was already presented by Dr. Agatha, because I faced some technical challenges and I was out when Dr. Agatha started. I just wanted to know how is the maybe to call it maybe the prevalence of these malnutrition conditions, especially is it mainly in the HIV burden areas, or is it also in non-HIV burden areas, particularly in Kenya? What is the situation like on the ground? so that we can have an idea. I was just thinking this is really, um, serious conditions, and I was wondering just how is the distribution of malnutrition in the country, or is it mainly in the HIV burdened areas of the Western region where we are, particularly for those of us who are in Kenya? I just wanted to know that. And maybe the second question is about the sustainability, the follow-up when the children are discharged and they go home. Do we see them maybe having the problem recur, or do they relapse, or do they sustain? What's the success, after they go home?
Rose, did you get Dr. Ndunyu's question?
Yes, yes. I can answer this one regarding the follow-ups. Huh? Can I answer to this?
Yes, just go ahead, then I'll tackle the first one.
It's okay then. When it comes to the follow-up of these children, many of them are lost upon follow-up, because you'll find that some of them come even far from the facility. So it also calls for financial support, of which some cannot even afford this the money. They cannot afford getting money to come for review every now and again. So they get lost, and the number is also very big. Sometimes they appear when the children are not doing well at all. So many a times you find us having even readmission and relapses in the ward. Is it okay?
Yes.
Okay, probably the first one, Dr. Ndunyu, concerning the malnutrition burden, I would say it is worse off amongst the HIV infected children. But then issues of malnutrition, the country is still grappling with, because if you look at indicators like wasting, stunting, underweight, they are still very high. We are still far from the WHO targets. So malnutrition amongst the under fives is still an issue of concern in the country. But it is worsened in HIV infection, because quite a number of children do not thrive. Like what Rose has told us, there is failure to thrive. Very, very common in HIV infection. But we still have issues with the three indicators for malnutrition amongst children.
Thank you so much for that.
May I ask a question that probably also back to Dr. Agatha and the students on some of the sustain? I think it was very interesting, and thank you, Dr. Agatha. This is Pauline and Rose and Dr. Louisa. I just wanted to know whether these prevalences, based on the question you were asking, is there any, if we superimpose HIV prevalences and malnutrition prevalences, do we see patterns that show that probably the prevalence of malnutrition is higher in areas where HIV prevalence is high? That is one. But also, Dr. Agatha, and maybe even the students, as we think about these sustainable issues of how do we tackle malnutrition in HIV, what are some, because a lot of times, even when we have these supplements given to HIV positive persons, to people living with HIV, there is the issues of sharing. What are some ways, or what are some interventions that would help us probably tackle malnutrition before it happens, probably help us tackle malnutrition more within the community, within the populations in a way that we would have less people having to come to the facilities. I think it would be very interesting to hear some contributions on this area, both probably from Dr. Agatha and also from the students who probably done quite a bit of work in HIV and nutrition. Thank you.
Maybe I can add something to that. Dr. Pauline, thanks for that input. I would say that we can have like probably food-based approaches, knowing that micronutrient deficiencies is an issue among HIV-infected persons. We could have like food-based approaches where we encourage maybe like use of local vegetables that are vitamin rich, mineral rich, or we can also have probably fortified foods. Maybe like we can have a combination of various grains, maybe maize and soya, etc. So we can have a food-based approach to it. Probably somebody else can make a contribution. Rose?
Yes, I feel that we can also help by empowering women. If we can give them, if we can empower them, they get some income generating activities, it can also help us. And more so, the knowledge, we need to disseminate, we need to teach them, we really need to make them know what they're supposed to be doing, because some causes of also malnutrition is knowledge deficit. Hello, I'm done.
Yes, any comments from students as we wind up?
Good evening.
I know we've already extended with a few minutes. Yes, Joy?
I want to commend Rose for what they are doing. I really appreciate that. And Dr. Agatha, thank you for the presentation. I would also like to put it across that empowering the women, knowledge, and encouraging them to eat local foods will be the best. Because mostly in the communities, we can't afford the fortified foods. So we encourage them to eat the locally available, the daga, the traditional vegetables, the available fruits that can help in malnutrition. And then I had another question. Can I go ahead and ask?
Yes.
Right, go ahead.
With the children, most of them are on a PI-based regimen, mainly lopinavir, ritonavir. We find that these children, they have the side effects of lopinavir, diarrhea, most of them. So this is also adding to the already burdened or weakened immunity and nutrition. As nutritionists, what do you advise? Because according to the age of the children, they cannot be put on other regimens too, of the ARVs. What is your way forward? What do you advise us as people who are dealing with the children?
Good question there. We can hear from students or from Rose or Dr. Agatha. Any students who are here who are practicing nutrition at the hospital?
Okay, can I answer to that?
Yes, Rose.
Yes, I feel that one is a real threat, because now you see we have raised energy requirements at the same time we are having the losses. So us as nutritionists, when it comes to managing a patient with HIV, we always work as a team. So it's always good. You manage a patient as a team, and we also need to, we have different diets. There's a way that you can always modify the diet of a patient regarding the medical condition of the patient. For example, if a child is having diarrhea, there's a way that you can always modify the diet so that the diarrhea is contained. Yes.
And probably to add on to what Rose is
we have a diet that is called brat diet. There's a diet that is called brat diet that is indicated for loose stool or diarrhea.
Yeah, to add on to what Rose is saying, now that brat diet normally includes bananas, rice, apple sauce, toast, and then also we have zinc supplementation, and we know that zinc is quite good in relieving diarrheal episodes. So we can also have zinc supplementation, we can have the brat diet, and then we can also avoid greasy foods that may be related to diarrheal episodes. And when we are feeding these children, we can have them eat slowly and maybe more frequently as they continue, as the diarrheal episodes continue to reduce. So we recommend the brat diet, zinc supplementation, and then avoiding of greasy foods.
And we also need to rehydrate them well.
Thank you so much.
Thank you.
Yeah. As we come to the end, students, any other students? We've heard from Joy. That's very good.
Maybe
Any other
Dr.
students
Ndunyu,
would like
I
to
want
make a
to,
comment? Yes.
Dr. Ndunyu, I want to add something.
Yes, please.
As we think of nutrition in HIV, probably there are also areas where we can, students can venture into. We now have HIV patients being diagnosed with diabetes, cancer. Maybe one could be interested in looking at probably nutrition, diabetes, and somebody who's HIV infected. That is still an area to explore as far as research is concerned. Another area is probably like having clinical trials to evaluate the prevalence of malnutrition amongst the HIV infected persons, and just looking at the efficacy of supplementing with some specific nutrients at different HIV staging. So you want to look at the prevalence of malnutrition in the HIV infected persons vis-a-vis the different nutrition supplements they are given, and you look at the different WHO staging. So I think there are still some areas that are rich to explore as far as HIV is concerned. Thank you.
Thank you so much for that contribution. And I believe students, you are hearing areas that are potential for consideration in your research work. And these are areas that would be very informative. Actually, there is so much that we still need to do in the area of nutrition. Like I really felt like for me, I was absorbing everything and really learning, and I was at the same time getting so, surprised and also very concerned that these are very serious issues that sometimes we really are not aware of, and yet they are serious public health concerns. So thank you so much, Rose and Dr. Agatha, for this wonderful presentation. And unless there is any comment, we've already gone over time, but I think it was worth it. And I would like to hand over maybe to Anke or Rachel.
No, I just want to
Any
express
comments?
my appreciation for the lecture. It was very informative. You can tell you have lots of on the ground experience, and so that's very helpful to share all of your knowledge with the students. So thank you so much. We really appreciate you both.
Thank you so
Thank
much.
you to the students for your in participation, and we look forward to the next seminar.
Yes, thank you so much, everyone, for creating time to participate. And the material are going to be on the they're going to be on the learner management system of Maseno University in the eCampus, so that you can go through the material if you wish to, in your own free time for more information. So thank you so much, and have a good evening, have a good morning for those who are in the US. Thank you so much for your time. Thank you to the presenter. We really appreciate you, Rose and Dr. Agatha.
Thank you, Dr. Ndunyo.
Thank you.